Now, good evening, everyone. Hello to AFPI Kerala chapter, the most active chapter in the country, I suppose. Hello to Dr. Vishnu. Hello to Dr. Rashmi. It's been quite a while. But to organizing the session, many thanks to having me here. And interestingly, what I want to share is the information that I have listened to in the last half an hour or so. It's a big organization. It's a lot of work that has been put behind the scenes to make family medicine be much, much more feasible to be understanding to the residents. When I joined in 2010 with an MD family medicine, the question which was asked to me in the couple of places where I applied was, what is family medicine? And do you want to continue in family medicine? And eventually what I was offered was, can you be in a position in internal medicine? But whatever little of what I understood of family medicine at then was, I chose family medicine for multiple reasons, for very simple reasons. I would do small things. I would do simple things. I would do a small OP practice. And I always like talking to patients. So I said, a decade of my life has gone into medical education. I'm not doing a further specialization. And that was 2010 May, and this is 2026 May. And thankfully, I have not been disappointed. So I welcome each of the residents who have chose family medicine as a choice or who ended up in family medicine out of no choice. Please welcome. You're one of the most important need of the country currently. And thankfully, from whatever I've listened, the policymakers are recognizing it slowly. Now it's up to you, the next generation, to take it to the next level. Now, without much wasting of time, is it possible for me to hear from some of you, what is family medicine to you? What have you understood as the core content of family medicine? And what have you identified as the identity of family medicine? You can put in the chat box.
Seeing person,
okay.
Seeing is whole person, identifying whole.
Okay, so seeing whole person and understanding the person. Yes, anything else? For me, what family medicine I have understood is, always I tell this to our residents, I may be one of the faculty who speak very less about exams. Exam is just one day drama and that goes on with the pre-planned content. But your goal during your training is not just to pass exam. Passing exam and preparation for exam is just one aspect of your training. To me, family medicine is patient stories. And what I have learned the most for me as a person, what I have been able to teach our residents as faculty, and what has really helped me to grow as a person is these patient stories and patient narratives. And today I decided to share 3 stories of patients whom I saw in the last few weeks. So today's objectives, I told Dr. Vishnu, 30 minutes of webinar for a family medicine principal is a challenge because usually it is a lot of discussion with the residents, but that is fine. We'll try to understand where is the context of work of family medicine and what are the core principles of family medicine and why do we need to keep discussing about the core principles of family medicine? Medicine as such has its own discipline. And what is this outcome of patient-centered care? What is patient-centered care and what is the outcome of patient-centered care in improving health outcomes? So now this ecology of medical care, I'm sure many of the senior residents would have seen this. There is a particular reason why we speak discussing about family medicine principles. And the reason is, in the community, if you take 1,000 people, whichever community you're practicing, you're living, your family lives, of that, roughly 800 report symptoms. Of that, around 300 consider seeking medical care and only 200 visit a physician's office. Eventually, 21 visit a hospital outpatient clinic, 14 receive home health care, 13 visit an emergency department, of which 8 are hospitalized and only 1 is hospitalized in an academic medical center. Interestingly, our 4.5 years of medical school we got some training, which is true. We got a basic MBBS degree for whatever evaluation it was done. That's true. But that has not fulfilled the objectives of caring a group of population in the community, which is where family medicine thrives. So to understand and come to a diagnosis for a patient who presents with illness in the community, you need to be trained in community-based care. And in community, not all patients present with biomedical illnesses. So there is a much bigger role as clinicians. The patient relationships, patient comes to see you as a person because they have known you over the years and they trust that you would have understood them as a person and you would help them the best way. And because it's community, it does not limit itself to a particular problem. Family medicine caters to the problem for what the patient presents for. And eventually the treatment happens to be a patient-centered, personalized goal. So this is something which you need to understand why we keep speaking about family medicine principles. So when so many patients from the community do not present to the hospital, or all the symptoms they present in the community need to be seen in the hospital, answer is not no. Their symptoms are true, but not always it has a biomedical background. It has other reasons that we need to explore as clinicians working in the community. Dr. Vishnu mentioned about some of the ONCA organizations, and of the many logos that I have come across, I always like this ONCA Europe logo. And the reason is, off the trunk is our core clinical skills. We are clinicians. We are skilled clinical experts, and communication with patients and with our team is a learned behavior, and we are expected to be very good communicators. And management of our practice depends on where we practice. So this trunk being a core discipline, and then these are the main branches which we will have to learn. And then there are these multiple branches, small branches. Is it really possible to learn all this within that 3 years? We will try to answer that question as we go along. But of the elective students, medical students who came to us, recently one student said they come for a 2-week elective in family medicine. When we asked the student, why did you choose to come to family medicine as an elective? The student said, I want to work in a secondary care hospital. And what I understood is family medicine can solve 80% of the problems. I didn't want to chase the remaining 20%. I want to equip myself in that 80%. Or in other words, 80% of the problems in the community are primary care, secondary problems that can be very well handled by a well-trained, equipped family physician. So the role of a family physician is in the community, which is very much part of the healthcare system. And the illness in the community is very different from the complaints and symptoms that we are usually exposed to in the hospital. So with that background introduction about where family medicine is, for physicians working in the community, it so happens that mind and body is mind and body. It's not either mind or body. So physical and mental diseases cannot be separated. I am sad today with diabetes, and that is something to be acknowledged. Managing diabetes and sending to a counselor or to a psychiatrist for the other emotional challenges usually doesn't help, and that is not what patients come to you for. And when it comes to management of chronic diseases, where you will see patients over their lifetime, obviously you will come to know about the patient's personality as well as the context in which they live in. And in this background of understanding the physical, emotional, and mental context of the patient, early detection of disease and disability is very, very important. Now, in this situation, I want to just share one story, which was a very heavy story for me this evening. A 13-year-old came to our clinic about 2 days ago. We didn't see her for the last 3 years. All minor complaints. She's finished 8th standard. She's going to 9th standard now. 2 days ago, she was seen for amenorrhea, missed her periods this month. Basic investigation sent, hemoglobin TSH normal. And then today she came back for result. The resident who saw sent for pregnancy test, and pregnancy test happens to be positive. So that is where a family physician works. Would you send for a pregnancy test in an otherwise normal teenager whom you have known before? Or why did you choose to send pregnancy test for this 13-year-old who was accompanied by her mother who missed her periods? These are the questions that we need to learn to answer. So early detection of disease and disability, whenever there is minimal change from wherever they are, that needs to be picked up by the family physician. So as presented before, both by Dr. Aishwarya and the huge family medicine academies, nationally, state-wise, it is an academic and clinical. It's not something thrown into the sea with no clinical or academic background. But interestingly, it is a generalist discipline. No one philosophy, organ system, age, gender, or institutional function defines family medicine. It is highly personal. It is dependent on the physicians and the patients who present to you. If you're going to a clinic completely in the community, the group of patients you see might be different if you happen to see another group of patients in a tertiary care hospital or a group of patients are admitted in a district hospital. And family medicine is a contextualized discipline. It depends on the physicians who practice it. It depends on the patients who present for their care. And it also depends on the place where the family medicine center is located. Between the urban health center with an IP service to a community clinic where I go almost every week, to 2 paying clinics in the urban area of the city where we are, the practice is very different. The atmosphere is different, and I'm sure you will also be sharing the same thing. So in other words, if I am saying about the practices where I work, I am only saying about the practice where I work. If I have seen one family practice, I have seen one family practice. If you have seen 100 family practices, you have seen 100 family practices. And family medicine is a customized service. It depends on the local health policies, health systems, patients, and the physicians. Now comes to the actual session, teaching the principles of family medicine. I hope residents would have seen this book. This is the 4th edition of Dr. McVinney's textbook of family medicine. It's not a usual clinical medicine book with approach to headache, approach to breathlessness, approach to chest pain. The initial part of the book speaks about how a family physician should start thinking. And these are the 9 core principles that he advocates for. I would try to draw on our attention to 4 or 5 in this next 10 minutes. But interestingly, when our first batch of residents read this, they said, it all sounds philosophical, ma'am. What is the relevance of this in clinical practice? So true, it is difficult to understand and explain. And how do we facilitate the transfer to clinical practice? But that is what makes you a physician as a family physician and not a diploma in medicine or diploma in pediatrics or diploma in obstetrics. Now, coming to the identity of family medicine, patient-centered care. Often I ask, we provide patient care. And then what is patient-centered care? We provide care for a patient, and what do we actually mean by patient-centered care? So the initial part of it, wherein we get the biomedical information, the psychosocial information, that is something which we do routinely, which is expected of any clinician. But then there are the other parts which have to come along with this biomedical and psychosocial information. That is good communication skills. Are you able to communicate to the patient what the patient has? Are you able to understand the context of the patient, whether the patient is sad, patient is willing to listen to the information that you're going to share, willing to understand whatever news you're going to share? The communication skill is a very, very, very vital part of family medicine, because you will be communicating to patients all along in your career. Then comes the other parts, exploring patients' perspective of the illness and impact of illness on their life. Before going to the next slide, I want to hear from a few residents. What have you understood as disease and illness? Quick. Is disease and illness the same?
This is what we diagnose, and illness the status of patient. from component system.
Okay, disease is something to be diagnosed. Thank you, Dr. Alfie. Thank you for responding. You are the only person who seemed to be responding. And then what is illness?
The condition of patient, what the patient is, and what are things affecting her.
Disease is the signs and symptoms the patient explain or what doctors see in the patient. So there is more of disease definitions rather than illness. So the illness is something different. What is the perspective of patient's perspective of illness? And what is the impact of illness on their lives? I will just share a quick story again. This is a couple whom I saw last week. This is one of the clinic, which is a paid clinic. Well-educated, husband is an academic, wife is a housewife, came for some dizziness, some aches and pains, some back pain, no major medical issues. They have done all their blood tests to rule out the 7 masquerades of medicine, family medicine, thyroid, hemoglobin, sugars. And then I kept asking, who are you living with? They said, it's only both of us. Our daughter has gone to study last year. I said, how is it for you after your daughter left? They didn't give me much information, but then the pieces of puzzles didn't come together. You have somebody with dizziness and unwellness, and then you have all these blood tests. They're middle-aged, 40 to 50 years, and they look well, no obvious biomedical illness to be diagnosed. So then finally, I asked them, what is it for you after your daughter has left? Are you missing her? And that is when the husband said, ma'am, to speak the truth, my wife wanted her to be a doctor. But now it so ended up that she could not get through her entrance examination. She has joined another course. And when this consultation happened, the re-NEET was not announced. So the one NEET which happened this year was supposedly easy. So since then, my wife feels, should we have made her to write the exam again? And that is when all her symptoms of unwellness starts. So the dizziness part, the unwellness part, not eating well part, it has an organic component, which is always our first area to rule out with the red flags. And then once these are ruled out, then you see what exactly is causing this illness. And then I had to do a shared decision making. I told them, I'm not going to be doing any blood test, but it so happened the NEET re-exam is announced and you still want your doctor to appear. They said, definitely not. Through this, there was a shared clinician relationship. So illness is something at the end of this class, I request these family medicine residents to go back and ask your patients when things are not fitting together, what is the illness of the symptom which they are presenting with? So on the left side is what you are usually taught. You do it quick. And then disease is what, as many of you shared, malfunctioning or maladaptation of biological or pathophysiological process. Now comes the patient-centered history. It comes in multiple mnemonics. It is ICE, it is 5, it is price, there are multiple mnemonics to this, but basically you want to know what is patient's understanding of their condition and try to understand their context of family, work, and social context. So illness is primarily what represents personal, interpersonal, or cultural reactions to disease or discomfort. If I have to say my thing, maybe 10 years ago or so, if they had asked me to do a webinar, I would have been sweating over the years, sweating with headache. Now, did that headache have an organic cause? Not so far. But today I have learned to do things. So a symptom, always try to explore the illness. And in some of the groups that the faculty group, they say, residents don't understand what is ideas, concerns, and expectations. Keep it as a simple checklist. Idea, what do you think is causing your disease? Concern, what is the most important concern for you right now? Expectation, what do you expect from this hospital visit today? And you will be surprised to hear what are the responses that you hear from patients. And based on that, more than likely, your management decisions will change, or it will open doors to help form shared decision making. My time is getting over, but I will try to go through the remaining slides. So this is basically the illustration of the disease, what the doctor perceives as the cause of the possible symptom. But then there is another side to it. What does the patient perceive the cause of their symptom, and how an illness affects people's role in society? And that is what they come out as sickness. Now, do all patients with disease have illness? How many patients you would have seen with asymptomatic hypertension, asymptomatic diabetes? They are well otherwise. They are going about their daily activities. They continue to work. Their life is well. That is disease with that illness. On the other hand, there is multiple symptoms, medically unexplained symptoms without disease. Those are the worried well. Now, when I make this statement between disease without illness and illness without disease, please be very clear. We are not trying to be judgmental. We are trying to help understand by ourselves as well as to the patient that their symptoms are not false, yet their symptoms does not have an organic cause. So the symptoms may not need the next level of investigations. It will need additional form of treatment. So what are the benefits of patient-centered care? Benefits for the patient goes back with better satisfaction. There is improved health outcomes. Similarly, for the clinician, till to date, 15 years into academic practice, there is always something to learn for me. I'm not telling about just the medical aspects of it. And there is always something for me to learn as a person, as a parent, as a teacher. And this stories is what keeps me going. More than important, during the first session by Dr. Aishwarya, the healthcare costs in our country, which is all out of payment pocket, please try to understand what the patient presents for. And if you can understand that, then you can improve your adherence to treatment, improve the overall quality of care, lesser hospitalization, and shorter hospital stay. I am going to skip some slides. Now, this is what I just discussed about the patient-centered care. 4 steps, if you want to remember it just as a checklist, you explore what is health important, what is health to them, what is disease to them, what is the illness experience. And now come back to and see if all has an overlapping component. Sometimes the illness will not have an overlapping disease component. And this forms the person, and person has a proximal context, which is their immediate family, workplace, and then they have a distal context, which is their neighborhood, community, and so on. When you try to understand these 2 components, you will be able to understand what are the patient's problems, what is the goal of care for the patient, what is your role as a physician, and how can you enable the role of a patient and family for that given condition. And finally, when you do this, your relationship with the patient is a lifelong lasting relationship. It is something like a family member. You would recognize them and they would recognize you. So quickly, specialists see different persons with specific skill, with specific symptoms and diseases. Family physician sees a gastric complaint, a skin problem, and a gynecologist in the same person. So that gives you a lot more privilege to understand the person, as well as to, over a period of time, form into relationship with them. Now, I have 3 more slides to discuss. One is contextualized care. As I explained the context of the patient, please be aware and cognizant of where we practice. Are we aware of our patients from places of social, economic, or geographical marginalization? We had a fellowship student a while ago who asked, family medicine is probably only for poor patients because you provide subsidized care. We took a while to explain and then to make him understand family medicine principles are the same, whether it is when we are working with a marginalized community or when we are working with a community with well-resourced community. The principles are the same, but the options available to them may be different. And are we understanding to the concerns of those in greatest need? That is something we need to know. That is why we ask that question, ideas, concerns, and expectations. Are we willing to understand the concerns, understand their expectations, and come to a shared relationship with patients? So, with this being the context of the care, continuity of care. 15 years now, yes, I have seen patients, their medical problems over their middle age, 50 plus 60 years, then their children delivering, then the newborn care of their grandchildren, then newborn having minor problems. So these clinical encounters with the patient can be over a period of time. But always over a period of time, you get to coordinate for them. You always develop a relationship. There is a personal emotional connect, a trust develops, and the quality of care improves. To go back to how we can contribute to the healthcare system, we will be able to decrease the cost, number of hospitalization, improve patient and physician satisfaction, and continuity of care is most satisfying in the career of a family physician. Whole comprehensive care. Now, comprehensive care, it is across a lifetime, or it is different age groups, adult, pediatric, maternity, elderly, palliative care, or it is in different settings, inpatient, outpatient, community, and home visits, preventive and promotive. Now, when I mention this, do every family physician get to do this? Do every family physician have to do this? It depends. It is a customized service. It is a contextualized service. It is a team-based care, or it's a solo practice. In principle, comprehensive care is one part. When a patient comes to you with URI with a BMI of 30, you don't stop there with BMI. You don't stop there with URI. You go back to ask the patient to come back for this BMI screening for screening for non-communicable diseases related to high BMI, and so on and so forth. So that is comprehensive care. And coordination of care. This, I would say, is probably one of the most challenging, because speaking to multiple departments, multiple social networking agencies, discussing cost with the patient, discussing cost with the family, and navigating between the community where the patient is from and to the very complex tertiary care system. If we don't do it, if we are not doing it, if we don't want to do it, nobody else is going to do it. It will take a lot of your time. If I have to coordinate care for a patient, I know it's going to be 30 minutes. But that is something which will reward the patient, because if done poorly, patients suffer. It's not only phone calls and multiple messages. It's about discussing the cost of this test. Do you have to do this test now? And review of the multiple consultations they have done. What referrals you want to do further, what other consultations. So coordination of care is something which I certainly believe only we do. Whole person care, one of you believe. Between comprehensive care and whole person care, there is some overlap. Comprehensive care is probably different settings of the healthcare system. Whole person care is whatever patient concern of their multiple symptoms, you go back to their whole person care with biomedical, psychological, social, family, and community. Now, finally, coming to the family medicine principles, of what Dr. McWinney's 9 principles, I have included the 7 C's, which is first contact, continuity, comprehensiveness, coordination. Now, can we do all of this for an entire population? Family medicine is a geographically defined discipline in specific communities. So going back to our communities is very, very important. It is a very complex discipline. More often than not, it's not a straightforward answer, and it is a contextual discipline. So to residents, we walk the complex journey of health and illness with each patient. And with that, I will bring my presentation to an end. These are the references. These are all available online. And particularly this BMJ Family Medicine Community Health has 12 reflections on storylines of family medicine. And most of the illustrations that I had taken are from that. And then Dr. McWinney has this Foundations of Family Medicine. And as you all grow into the next level of academics, you are to reflections and patient stories. So with I will end the session. The take-home message is patient-centered. what is the age of this patient? What is the context of this patient? What is the concern? What is the expectation? What is the goal of treatment for this patient? What is my role as a family physician? And what is going to be the decision for the patient that I have taken in discussion with the patient? So I am not sure that if I've already crossed 10 minutes, so maybe we will go over to the next presentation and have questions if possible for towards the end. Thanks to the Spice Route movement for this session.